Hello and welcome. A very warm good evening to all the doctors who joined us today. On behalf of Dr. Reddy's, I, Dr. Kirti Shukla, Medical Advisor for Recura ACE and Grace Division, welcome you all for this live webinar. I wish and hope that you all and your loved ones are safe and happy during these trying times. Continuous learning is the minimum requirement for success in any field. And that holds true for us, the practitioners. So, with this in background, Dr. Reddy's, who has been the trusted partner for good health of the patients, presents to you Dental Vistas. Dental Vistas is the first flagship program for from Dr. Reddy's for the dental fraternity, with the motto that we are going to be your partner for your daily knowledge. So, in endeavor to continue providing knowledge and enhancing the dental practice, for the first time, we have brought a 3 module series for our esteemed doctors. And in this series of the first module, today we are going to be talking about single sitting root canal treatment. So, without further ado, let me take this opportunity to introduce our eminent speaker, who's not only an academician, a mentor, experienced practitioner, but also avid researcher in the field of endodontics. Welcome, Professor Dr. Ajay Bajaj. Dr. Bajaj is a known face in the field of endodontics, and he is a practicing endodontist from Mumbai, India. He's done his BDS in 1999 and he did his post graduation in 2002. He was awarded Best National PG Student Award. He's recently been appointed as professor and post director at University Jaume I, Spain. He's a mentor in endodontics. He's conducted more than 400 lectures and courses across the globe, more than 60 live endodontic procedures, and is a jury to various dental awards. He's written and published articles in national and international journals. Before we begin the session for today and I hand over the dais to Dr. Bajaj, let me also take this opportunity to introduce Dr. Reddy's laboratory in front of this August gathering. Dr. Reddy's commenced its generic business in India in the year 1986 and today is a trusted name in the healthcare industry, consistently serving the needs of millions of patients with high quality, affordable, and innovative medicine across therapy areas. Over the years, the company has significantly grown its portfolio of products across mass and specialty therapies. Today, our portfolio spans across cardiovascular, stomatology, dentistry, dermatology, diabetes, gastroenterology, nephrology, oncology, pain management, and so on and so forth. We believe and we work with the motto that good health can't wait. And even during the pandemic, we've strived to bring the best of care to the patients in the industry, in the country, with the launch of vaccine like Sputnik V and also the other medicines, which really helped for the fight against pandemic. So now, without taking much time, I would now request Dr. Bajaj to please take the session. Over to you, sir.
Thank you, Dr. Kirti. I know Dr. Kirti since last 12, 13 years now. It's been a while. And good to see you and being associated with the profession. And you guys at Dr. Reddy's are doing phenomenal job. We have so many products in dentistry itself, which we have been using for years and years and decades together now. And more than that, we know Dr. Reddy's for the Sputnik vaccine now, which is like we all are waiting for you to roll the vaccine in a big number as soon as possible. So nation is looking at you with a great, the way we look at other institutes who are manufacturing, and rather I will say nation, but over the period of time, even the international communities must be looking at you for the vaccine for sure. So viewers, we are in COVID times, and we really want to make the treatment faster, right? We do not want to wait. We want to make the things quicker, and for which we are definitely looking at uh, making our job faster and without any compromise on any accuracy. So there has to be some methods, there has to be some formula which we can use. Okay, and that is what I'm going to share. Those who know me, I've been speaking for almost 20 years now, and almost since day one, I have always been speaking about single setting endodontics. So it is a formula which has been time tested and which we have been trying for like so many years now. It's not just now, but we have been repeatedly using this formula for many, many years. Okay, so uh, give me a second. Okay, so I will share my screen. Just help me out in
Yes,
knowing.
doctor, your screen is shared now. Let's open the presentation. Yeah, please put it to slideshow.
Okay, so single visit endodontics. We've been talking about it, and I'm happy that a lot of dentists are now following single sitting endodontist regularly. It is something which we all must can do. So this is the 412th lecture or workshop which we have been conducting, a long journey which we have had. If you want to see my videos, they can be seen on YouTube. Recently, I have been added as a silver member for Style Italiano Endodontics. And our motto is feasible, teachable, and repeatable treatment options. Feasible, teachable, and repeatable treatment options. So when everybody is talking about the same, we are going to be different. And with this, I always say that endodontic practice is the most common practice procedure which we do in our clinic. It forms the base of any successful practice. We do it so regularly, but we are still not sure about final result. We always say such a small tissue and such a big issue. We typically have those issues where patient gets pain and we don't know why it is happening. Almost every day I get a message from some other dentist saying I started with a root canal and this patient had this problem. Forget doing it in single sitting, but doing it in multiple sitting is also a big issue. Okay, so let's discuss the some do's and don'ts to make it a perfect single sitting painless job. Okay, for me, 90% of my cases can be finished in single sitting, and so is the formula which I keep sharing with everyone. And I'm not only going to share the formula today, but I'm going to show one case, a full case, say a 15-minute live video which we recorded just a couple of days ago. Uh, of course, the video is typically an hour's video, but which has been edited to 15 minutes, and I will be showing that video also, so you will see a practical application as well. So when whether to do single sitting endo or no, endodontic world is divided. What we know from the studies is the success rate is same or better. Number of flare-ups are lesser. Now, when I say number of flare-ups are lesser, many of you may not agree with this. You may say, no, flare-ups are more. I know, but the thing is, what happens is that people, when a lot of dentists, when they do start getting into single sitting endodontics, they follow the same formula they have been following for multiple sitting endodontics packed into one appointment. That's not the way you work. Okay, the formula is little different. The way to approach is little different. So, if we realize this and if we follow this, we will be able to do single sitting endodontics very regularly. We save a lot of time. We are not putting patient to repeated graded root canal appointments. If I have to go for my own root canal, what will I prefer? Will I prefer single sitting endo or multiple sitting endo? I will naturally prefer single sitting endo. If it can be done, it is always better. And monetary gain, because you require lesser number of appointments. So later, you do not have to call the patient again and again. The, arranging the complete setup, sterilizing the instrument those many number of times. So usually our one root canal appointment is half an hour, 45 minutes. So 3 appointments typically given for access cavity preparation and gross cleaning and shaping, and second time we complete it, and then third time we do an obturation. So which is like more than 2 hours. Versus when we get into single sitting, we usually finish treatment in 1 hour 15 minutes or so. So which is more than enough, and we save a lot of time, which is naturally going to be a monetary gain. So we plan the treatment well, we do a correct diagnosis, we plan the treatment, and then naturally post-operative success is seen. So diagnosis is important. Identify the tables and tools, then do the vitality test, plan it well. Root canal is a blind procedure. It is the procedure of the roots which we cannot see, Looking at the tooth, we cannot make out what we are going to expect inside. Okay, so radiographs are the first look at the X-ray. So they should be of good quality, minimally distorted, and consistent with root anatomy. It should not happen that the root apices have flown out of the X-ray and the angle is not correct. They are we cannot see certain anatomies. Those who are using film X-rays, they have not been developed properly. All those issues should not be there because root canal system itself is complex and not seen very clearly on the X-ray always. So it's always better to have better quality X-rays. Like for example, this was the case where patient had pain on this side and we decided to remove this bridge. We could see the decay below the bridge, right? And there was a big filling in lower second molar. Upon removal, naturally, after removing the bridge, I could clearly see that this tooth has got a very severe destruction, and this tooth showed me two canals clinically. When I took the when I obturated the tooth, after obturation, I could find some extension over here. Now, what is that? Is there any extra canal? I really could not find any extra canal. So, what is it exactly? So, it's not always that the X-rays are enough. Sometimes you have to have CBCT. So, you have to cone beam CT scans. Okay. Naturally, with something like this, I decided to go for CBCT. If there is any extra canal which I am missing, or else, okay, I could see a nice periapical lesion around. But what is that? And my obturation was not all that bad, but there was a fracture. Okay, so there was a fracture in the medial root, in which that fracture line you could see the uh, sealer going inside. Okay, so the lateral canal or the fracture line, which is associated with severe bone loss. The bone loss, which was so severe that what we could see and what it was here was much more. Okay, so these are the case. This kind of destruction around the root we could not really appreciate on the normal X-ray, right? If you see it in this video, you will be able to see in 3D how much of bone loss is there, and you can clearly see a fracture line over here. So, friends, sometimes we require more information for which we may have to put the patient on CBCT. CBCT is not for me for every case, but for selective cases, I will definitely think of doing it. Another case, this patient came to me. I had done these two root canals for him some 15, 16 years ago, upper 7 and upper 8. Upper 6 we extracted that time because there were just root pieces left. That time Ashish was a student. Now he, of course, after 15, 16 years, he's doing well in life. He wanted to replace this tooth. He wanted to replace the teeth on lower teeth as well. And he had pain. So I asked him, okay, if you want to go for, and he wanted to go for implant. So I said, okay, you get me an OPG. He got me an OPG. We saw this tooth, lower molar, which had a deep cavity, decided to go for root canal. We did this root canal, but his pain persisted. Okay, we do not want to accept our mistakes, right? Or we do not want to accept our shortcomings, but we could clearly see that there is periapical lesion over here, right? But the pain on percussion was on wisdom tooth, on 8, and not on 7. Okay, this was strange. This tooth looks okay. This tooth shows me periapical lesion, but the pain is typically in this tooth. Now, what to do? What do I do? Meaning, if I have to remove the crown and do retreatment of upper 7 and 8, it is not going to be that easy. But if patient has pain, I have to do something about it, right? We went ahead, did CBCT, and on CBCT we could see that the distobuccal root has been completely missed. I missed it that time. Okay, so this was like 15, 17 years ago, and there was a huge periapical lesion. Of course, we did retreatment and we filled that area. But this periapical lesion was not seen on, or not really appreciated well on the, or the root was not really well appreciated on the OPG. Okay, so these even the X-rays have limitations. We may or may not be able to say that okay, this exists for sure. Okay, now we come to giving anesthesia, and a lot of time we have failures. We have to understand certain things when we give anesthesia. Usually, the problem is more in mandibular teeth. The pain may not go because of inflammation or incorrect block technique. There are two techniques which we all must know: intraligamentary and intrapulpal, which all must master. Okay, I don't expect any dentist saying that because we are painkillers and patient is in pain, so we all have to know how to give intraligamentary anesthesia and intrapulpal anesthesia. So local inflammation, cross innovations, and incorrect block techniques are the reason. Whenever you have OPG, always look for mandibular canal and mandibular foramen, because if you see the mandibular foramen on OPG on the ramus, you will be able to direct the needle properly. Sometimes it is above the occlusal surface of upper teeth, sometimes it is below the occlusal surface of lower teeth. But we have to understand where it is, and accordingly we should act. What I use in my clinic is Sunshine USA gun, which helps me in giving anesthesia very effectively. Now, most of the patients avoid going to dentist because they are scared of injections, right? What if we could remove this scare and patient is hooked to your practice because he knows your injections don't pain? This patient may go to some dentist and come back. Now, what happens in this technique? It's a gun which is motorized, so there is a continuous, constant speed anesthetic solution which has been deposited. The injection speed is slow. It is 1 ml per minute. 1 ml per minute. So it's a slow injection. Okay, and because of which there is no continuous pressure developing inside, and patient gets a great relief from the fear of anesthesia, fear of injection. So this I usually prefer to use articaine instead of lignocaine, because articaine, the pH is similar to body pH, so that typical stinging initial pain which we get with lignocaine, which is more on the acidic side, is not there with articaine. And articaine also has the thiophene ring, which makes it easy for us to inject because it has got most lipid solubility. Articaine is more effective, more potent, and gives a better local anesthesia, especially when it goes for the root canal treatment. So, of course, use rubber dam, without which proceeding doesn't make any sense. Okay, now we go to access cavity preparation. I'm just going to describe the whole protocol into single setting so that the job becomes easy for us. Okay, so there are different types of access cavity preparations. We have conventional, conservative, and ninja access. So we remove the pulp tissue in toto. Nowadays, that's the formula which we follow. We try to remove all the pulp tissue in one go, and that's the new mantra in endodontics. This way, we can fasten the whole treatment because pulp has to be dissolved with sodium hypochlorite. Now, imagine that the canal is filled with pulp tissue, and you have to continuously irrigate and continue to dissolve the pulp tissue. It takes long. It takes around 25-30 minutes. Versus, I have removed the pulp tissue physically, and only some tissue shreds are remaining inside. Now, me dissolving the pulp tissue becomes very, very easy. Okay, so we save a great amount of time over there. Nice, good access cavity preparation, and we should be able to remove pulp tissue very easily. As you can see, the extension into the lateral canal also has come out. Okay, identify that there are pulp stones which are radio opaque things in otherwise radiolucent canals or radiolucent pulp chamber, and remove them. If I see and remove, I will be, if I don't notice this, if I don't realize this, I may push this pulp stone inside the canal and can become really, really difficult for me to manage this case. Okay, so very important for us to remove the pulp stones effectively. So, uh, so a small collection of pulp tissues which I have removed. You can see the bulk of pulp tissue which has been come out with only the K file, right? So how to squeeze out the dental pulp out of the canals? It's not very difficult. We can remove very easily. So in this video, you will be able to see 36 pulp tissues which have been squeezed out. Look at how the tissue, how it is. Look at the extension and a pulp stone over there, right? Now you can see how the pulp tissue has been removed from the molar with an extension into the lateral canal. Another pulp tissue. Bigger the pulp tissue, you know that is an easier case. The color itself tells that it must have been a non-vital case because there is no blood supply to the tissue at all, right? I use H files. I use barb brooches. Barb brooches are my more favorite instruments where I can effectively remove the tissue almost from each and every canal. Okay, so again you can see it over here from multiple canals. Another case where tissues come out from in a premolar case. Okay, barb brooches help you remove tissues very effectively, and because you have removed the tissue completely, instrumentation also becomes easy because you may not pack the tissue completely inside, right? So this is extremely important for us to learn the technique and follow it. Okay, so we make a nice conservative access cavity preparation area, lower 8 required root canal treatment, and as you can see in this video, if with this kind of curvature, if we have these modern files which are heat treated, I will be able to do a nice access cavity preparation. Otherwise, in the past, just to flatten this curvature, okay, I would have extended my access cavity preparation to the yellow line. But now, because our modern file can bend very easily, the heat treated files like 2Shape can bend very easily, I can keep my access cavity preparation lesser and I can save a lot of tooth structure or the root structure, right? So endodontics explorer is a forgotten instrument we must have when we are doing access cavity preparation with us. Always remember to know all the canal anatomies. Like for example, lower anteriors have two canals. One, although they are on the X-ray, they are seen as one mesial and one distal, but they are always one labial and one lingual. Right? Maxillary second premolar also in most of the cases for endodontic purpose has got two canals. Upper molars, first and second molar, usually first molar in almost 80 to 90% of the cases has got four canals. It's rare for us to have only three canals. So all these variations we have to know. If we know, we will be able to treat better. We use files like Pace Inject for application of sealer cements. Intercanal medicaments, we all know sodium hypochlorite, calcium hydroxide, 15-17% EDTA and 2% chlorhexidine. We do not use H2O2 anymore. We do not require it. These are the chemicals which are usually more than enough for us to. Sodium hypochlorite, because it is strong antibacterial tissue dissolving property, we depend a lot on sodium hypochlorite. Higher the concentration, faster is the dissolution of the pulp, because antibacterial properties are almost the same at 0.5 or 5%. I will prefer to use at 5%. And since when we use rubber dam, we are not afraid of having any chemical burns. In fact, when patient has ulcer, that itself is a proof that sodium hypochlorite dissolves the tissue. It's just that it is dissolving the wrong tissue, right? So take precautions. Do not let any hypochlorite accident happen. 15-17% EDTA. We do not use gel anymore, but we prefer to use liquid in more. Okay, so how to use it, I will show during the video, and I will try to save time over here. We agitate. It is not just using these solutions. We have to activate them, without which expecting clean canals is difficult, right? So for long-term success, we have to have clean feasible surfaces, proper taper, and spaces for irrigant to reach to inaccessible peripheral zones. So we all know this picture that 35% of the canals are never touched with our files. Okay, so we do not touch the canal walls. So if we could not touch, if we do not reach to these areas with our files instruments, so how do we clean them? We clean them basically with the rinse, with the irrigation, and that irrigation is basically sodium hypochlorite in a, mainly, okay, which is going to dissolve tissues from the lateral canals, from the accessory canal. You cannot really reach to these areas with any of your rotary instrument. No, none of your rotary instrument is going to go in this area, right? So to act, why do we activate? To have complete action of irrigants everywhere in the canal in shorter period of time. In short, when we are using only rotary instruments, our shaping is faster. But irrigation can take long because sodium hypochlorite take good 20 to 30 minutes to dissolve the pulpal tissue. So if those who are using rotary, after you have removed the visible pulp tissue and widened the canal, is your job done? You can go ahead and obturate? No. Irrigation protocol has to be followed, and probably it is the most important step in today's day. Okay, so we have to remember this. For which I use my DT scaler, which has got general, perio, and endo mode. Endo mode is my favorite, and they have got around 35-40 different types of endo ultrasonic tips, which can be used for various purposes, right from endodontic irrigation to removal of the calcifications from the canal, removal of the broken instruments, locating the root canal orifice, or some removal of the pulse stones to removal of the calcifications in the canal. Everything can be used. Okay, so this is usually ED60 is my favorite tip for irrigation purpose. So when we are using this kind of tips, they actually create extreme vibrations inside the canal, inside the fluid, and because of which we can actually expect excellent clean canals inside. This movement is not seen to us with the naked eyes. This is actually seen under the microscope, right? So if we could achieve irrigation, now when I was obturating this canal, while obturating, I did not know that I am going to have 1, 2, 3, 4, 5, 6 visible exits. There could be exits on the other side of the canal which I cannot see from this side. Okay, so there was multiple exits over here. How could I achieve this? I was just preparing this straight canal, but after the my protocol, I followed my irrigation protocol well, and I could obturate the canal over here completely. So the technique, the important step, very important step in endodontic single setting endodontics is crown down technique. Please try to understand. Without crown down technique, doing single setting endo will be really difficult because patient may have a lot of pain after the endodontic treatment. So what is exactly the procedure what we follow? We prepare the coronal third first, then we prepare middle third, and then we reach the apex. So in conventional technique, what do? We after we do access cavity preparation, we take our 10 number or 50 number file, we put it in the canal, and we try to reach the apex, so-called apex. And in doing this, we say I'm working on a lower molar and which has got a length of 20 millimeters, approximately looking at the tooth or whatever, or with my so-called tactile sensation. I take my file and try to reach to wherever I am looking at the apex. Under this technique, I may be 2 millimeters short of the apex, sometimes I may be working beyond the apex, and I really do not know. That's why we confirm it on the X-ray. And years after years, hundreds and thousands of root canals done, we're still not sure where we are. So we always take an X-ray. But we do not realize this canal is filled with some kind of tissue, vital, non-vital, with bacteria, without bacteria, with their toxins, without their toxins, putrefied, whatever it is. Now, when we put the file inside, what happens to the tissue which existed there? When I'm trying to reach to the apex and my file is snugly fitting in the canal, that means I'm occupying 80-90% of the space in the canal. What happens exactly to the tissue? Some of the tissue can get pushed beyond apex. So if some of the tissue gets pushed beyond apex, that's not the place where this tissue should be. even if it is a vital pulpal tissue, it is not the space where it should be, right? So if it is not to be there, what will body have to do? Body has to initiate a process of phagocytosis. So it has to ask for the WBCs to rush in that area. It has to ask for phagocytosis to happen there, macrophages to come in big number over there and clear this area off. Whenever there are going to be more of WBCs in any area, there is going to be increased pain. Okay, the signs of inflammation. So there's going to be pain, there can be swelling, and all of those things which we can expect. So when we do ground down technique, we just do coronal preparation, then we do middle third preparation, and after every preparation we irrigate multiple times. And once we have cleared this area more or less, then we enter in apical third. We are not in a hurry to reach the apex in the beginning. This way, we dissolve most of the pulp tissue when we reach to the apical third, and then we have already removed most of the pulp tissue in toto. We have dissolved most of the pulp tissue. We use modern instruments which help us in removing this tissue effectively. And by the time we reach to the apical third, most of the canals is emptied already, and we do not push anything beyond apex. And treatment becomes predictable. With this, even non-vital cases with huge periapical lesions, can be finished in one sitting. Trust me, we do it day in, day out. Okay, I'm not really worried whether patient will have pain or something. The case which I'm going to show you in some time is a non-vital case which we finished in one setting. Or there are so many times when we used to have physical conference. Look at the stage where we reached when we used to actually have offline physical conferences, meaning we never imagined that we will speak something like this. So we in those conferences I have done so many live procedures in which I've shown this technique even in non-vital teeth commonly. So this is called partial glide path. You do not prepare the whole glide path in the beginning. Okay. So when I'm using my K files, I do not waste my time in preparing the canals with my hand. I always use K400 K file reciprocating handpiece, which moves in 30 degrees on each side. 30 degrees on each side, 30 degrees each side in reciprocation. And this way, it gives me actual cleaning of 60 degrees. Okay, so 30 degrees each side, and helps me in negotiating even the curved canals better. Okay, so life becomes very, very simple, very, very easy when I don't have to prepare my canals with hand. It is a big time saver. Otherwise, K file preparation, that initial 10, 15 number or 20 number K file preparation itself takes us 10, 15 minutes. And it is a major hindrance when we are doing single sitting endodontics. So if I could finish this job in 2-3 minutes more effectively, where the life of 10 number or 15 number K file is actually increased, the life of the file is increased by 4-5 K file handpieces, which move in reciprocation, actually increase the life of the K files. Chances of breakages are close to nil when we are using with K file handpieces. Okay, and they're extremely effective. Extremely effective. I use 12 number K files between 10 and 15 number K file, and I call it a magic file. A lot of us, which file which we break is a 10 or a 15 number K file. And why does that happen? When we move from 10 to 15, the transition in the size, in the diameter is 50%, or in perimeter is more than double. The size is more than double. So these files are so thin, and if you jump to the next size, which is more than double, it's just don't go by this number 10 and 15. It's the change of 5. Whereas 35 to 40 is also a change of 5, but that's not correct. It is 0.10 millimeter tip size to 0.15 millimeter tip size. When we jump by 50%, chances of breakages are high. But when we add 10 number, 12 number, this jump is 20%. From 12 to 15, it is 25%. So it becomes gradual, and chances of breakages are reduced. If the canal is extremely calcified, we can even add 17 number K file. So 12 number K file is a magic file between 10 and 15. So when we are using apex ligator, where should our apex, where should we it end? If I rely only on X-rays, then C is my radiological apex. C is my radiological apex. Okay, but if I have to push my instruments, my working length X-ray instruments or my obturation, then I have to follow the red arrow, and which is too long a preparation, right? So I usually, where do I stop? Do I stop at B? Even B is beyond apex. Usually apex or apical minor diameter is at A. But if we try to match it on the X-ray, it looks short. It does not matter. It just does not matter. What is important for me is to have actual 3D picture, and I will not always rely on my X-rays. I will rely on what my apex locator tells me. Okay, so apex locator is the most accurate method to know the actual apex. I use iRoot apex locator since 2004. I think it's been almost 17 years now, and it's extremely durable. I will not take much of time. You all know about how to use Apex locators, or there can be a separate lecture, so I will not waste my time over there. So post-op pain can be really controlled if we follow ground down technique, and that's the modern way of working. Role of antibiotic then becomes limited. Of course, NSAIDs are something which I will write for each and every patient. Antibiotic may be optional for me, but NSAIDs which will go for every patient, because we have actually we have done pulpectomy, we have cut some extension which were getting into the canals from the body, and we have cut them, so we have severed them. So there are going to be those pinpoint wounds inside. We have used different kinds of materials like sodium hypochlorite. We have used the sealer and we have obturated over there. There can be foreign body reaction. So to control the pain, we have to give NSAIDs. We all use rotary instruments, and the system which I love to use, which gives me a true ground down preparation, is by Micromega, where the coronal preparation is with one flare, and canal preparation I can use various systems from there. So one flare is a new modern instrument which has got an active cutting length of 8 millimeters, blade is 13 millimeters, and actual instrument is only 17 millimeters, because it is one flare is flaring instrument. It is only for coronal third, and it has got a taper of 9 degrees, and this is how this prepares the canal. The wire is of only 1 millimeter, so it is a very conservative instrument, yet gives me an excellent preparation. 1G is an optional file which I use, which is not used in every case, which is 14 number 3% taper file. And my favorite instrument in my practice is one curve. One curve is a single file system. It's a rotary instrument which is single file system, and I'm going to show you the case which will be of one curve. So what do you do in one curve? One curve comes in 25 4%, 25 6%, 35 4%, and 44%. Okay, so usually for me, in most of my cases, I require only 25 4% and 25 6%. Trust me, nowadays we rely more on irrigation, more on irrigation. So even if it is central incisor, in most of my cases, I stop. It is gone are those days when we used to use 30, 35, 40 and bigger instruments. 25 6 is more than enough in larger canal. If the root is thinner, I will go with 25 4%. And this is a single instrument. So you do not have any sequence that I will either use 25 6% and 25 4. No, it is you choose one instrument. You choose either 25 4% or 25 6% or 35 4%, whatever instrument you want to use. It's a single file system. Of course, heat treated instrument, because of which the flexibility is extremely good. You do not have to keep a major stock. The cost actually is cheaper in our clinical terms. It is 25 4 or 25 6. That is what I said, which I usually require. And the flexibility is extremely good. The resistance to cyclic fatigue is two and a half times more. The cross section in the file are different. At the tip, it is triple helix design, but at 12 millimeter, it becomes double helix. So there is a transition. So there are five types of different cross section which we see in this instrument. Okay, so chances of zipping are close to zero. I use it at around 400. Company recommended speed is 300, but I usually use it at 450 RPM and 2.5 Newton centimeter. Okay, so if I sometimes, now this full case is there on YouTube, you can always watch this, But this is something like a doctor broke an instrument beyond apex. Why does this happen? When we are using rotary instrument, we do not realize sometimes that we have gone beyond apex. And instrument snaps, break or can break like this, or there can be simply over preparation. And how do we avoid this kind of situation? Imagine that our instrument had an apex locator inbuilt. Okay, so there are various motors which are available in the market. For example, Control or Endomatic, which is a cordless motor, which it is not only endomotor but which also has an apex locator inbuilt inside. Okay, so naturally, when we reach the apex, we come to know whether we have when we reach the apex, we come to know that whether we are winning. The file can go in auto reverse, and we come to know where to stop. Okay, so Motopex is another example of the same, where or the latest motor which we have, AI motor with T mode, is also another example. So when we are using this kind of motors, the advantage that we have is they have inbuilt apex locator inside. So because of which you do not have to use it separately. Of course, it can also be used as only apex locator, only endomotor, or both together. So when we have apex locator inbuilt, we can have auto start or we can have auto stop. The file, when we touches to the tooth, it starts rotating. When we take it out, it stops rotating as the circuit is broken. When the file is in apical last 2 millimeters, it can slow down. That is called apical slow down, and it can reverse at the apex. So you can see it over here. You touch and the file starts rotating. It is gone slow now, and it has gone in reverse now. Okay, you can see the file is at the apex and it goes in reverse now. So these are the features which we can have with this kind of motors, and that it is. Now there is something called adaptive torque reverse function, meaning it is taking advantage of reciprocity movement and rotation movement both together. So when we exceed the torque, we can see that the file can go in reciprocating movement. Here you force the file inside the canal, okay, and now it is going in reciprocating movement, so that the forces are relieved before you cut further. Okay, so these are the advantages which you have with this kind of new motors. So another file system, if someone does not want to use one file system, then system like two shape, which where you have two files, ts1 and ts2, are extremely good files, which again has a asymmetric cross section. ts1 is 25.4% and 25.6% is ts2, and you can use them in sequence. So just in case if you don't want to get into single file system. So when now come to actuation, and we want to achieve 3D actuations, and we have different kind choices of sealers in that: zinc oxide eugenol based sealers, calcium oxide based sealers, resin based sealers, glass ionomer based sealers are also available in the market, but hardly anybody uses. Silicon based sealers, bioceramic sealers are excellent sealers, and I think the future is of bioceramic sealers and medicated sealers, which we do not recommend, we do not use. So my preferred sealers in my practice are resin-based sealers or bioceramic sealers. And slowly we are getting into more onto bioceramic sealers. So I use EQV gun regularly for my preparations, EQV pack gun and fill gun. Pack gun, how do we use it? We actually take a plugger, we keep ourselves 5 millimeters short of the apex. Then we take a master cone, we coat it with sealer, we put it in the canal right till the apex. We take the first down pack gun, we have adjusted our rubber stopper at working length minus 5 millimeters. We reach inside and we start heating it. So when we touch this portion, rubber portion, it starts heating. The heat is instant and it continues heating for 4 seconds. So we start heating. This way we heat the GP point in the canal, the master cone in the canal, and we melt it. So there is GP point remaining in last 4-5 millimeters. In remaining everything is molten and the excess is removed. So last 4-5 millimeters have been has a molten GP point where we can use our condenser uppercut pluggers and we can condense that area with. And then we use a backfill gun. With backfill gun, which the molten GP point comes out, which helps us in filling up the canal well. So I can show you a quick video over here of the same. Okay, so you select the gata pacha, confirm the tuck back, then you prepare your backfill gun, adjust the rubber stopper at around 5 millimeters short of the apex, hold the GP point, and then put the GP point in the canal and put it inside, leave it inside. Then set the temperatures on the backfill gun, cut the excess first at the orifice, and then enter in the canal. Working length minus 5 millimeters, continue heating, and then remove this GP. Once that is removed, you do vertical condensation. Okay, and then you take the EQV backfill gun with put a GP bar or a GP stick and push the piston which goes into the heating tank where the molten GP point is created and which comes out through this golden tip which we injected inside the canal. It's very easy, it's very fast, very predictable, right? So it takes around about 1 minute only for us to obture one canal. The cost is less than 5 rupees per canal, less than 5 rupees per canal, which is very reasonable. So the new technique which we have been using and which is very popular is of bioceramic sealers. This is a small video of mine with the compilation of bioceramic sealer. So bioceramic sealers are the sealers which which are pre-filled paste, okay, which is there in the syringe and which can be used to fill the canal. So now this was a case of middle mesial canal, and you can see I just inject the sealer in one of the canal and it comes out from the other canal because there is confluence. The canals are joining together. Another case is C-shaped canal case. I inject in one of the canal and you can see that I am so sorry. Oh, some PC issue. I'm so sorry. Am I visible? Am I audible?
Yes, sir, you are audible, but your camera is off, sir. Will you please turn on your camera?
Now can you see me? Is my
Yes,
share
sir, we
screen
are able
on?
to see you. Yeah. Your screen is shared, so let's open the presentation or the video you are sharing.
It suddenly asked me to force quit. I don't know why. Anyways, I'll simply go to my video and start showing you the video. So there is a course which uh, my screen is visible, right?
Yes, your screen is visible, doctor.
You
Yeah.
can see the video, right? Okay, so this is the case which we are going to treat. Lower first molar, and you can see the roots are pretty slender. They're very close. It looks almost like 7. And a deep cavity which was there. Apply the rubber dam. Put the gingival dam all around. Okay, and then we use light cure machine. It's a 15-minute video. We use light cure machine, uh, and we light cure the gingival dam. The machine which I use, I require only 3 seconds to cure this. So 3 seconds on either side. Some portion of the video I have made it. I've gone a little faster to save the time because like part of irrigation and other things, I do not have to show the complete thing. Now this was the cavity which was there. We remove the decay which we can see from most of the areas. We have to remove right in the beginning. There's no point in keeping the decay inside. If we keep the decay inside, what we cannot see the things well because the light does not reflect well inside. Okay, So it is important for us to follow this religiously, do it right at the beginning, take a small dip, okay, into the pulp canal, and I will prefer to use a pulp chamber, and I will prefer to do intracanal injection over here. I use my uh, uh, gun over here, and with which I do with the other finger, the thumb, I will give a continuous pressure, and I will give a nice intercanal injection with which the pain goes down drastically, immediately, and it is instant, and we can start doing access cavity preparation further. And especially apex, if you see, I am going only 14-15 millimeters. The cutting blades you can see clearly, and I'm just going 14-15 millimeters only. My file is loose. I'm not in a hurry to reach to the apex. I can also use files like barb broaches to remove the pulp tissue in maximum possible way right in the beginning. After every instrument, I'm going to irrigate. Now I pick up my one flare coronal flaring instrument. I still don't know the length of the canal. Please try to understand. And I'm preparing my canal with this. I'm doing my coronal third preparation. I'm widening the canal further so that I can irrigate it well. It can hold more of sodium hypochlorite. Okay, you can see all three canals. You can see the debris how it comes out with these micromega files. Okay, the whole debris because of the asymmetric cross section, the debris is not packed in the canal. It is at the orifice. Again, helps me in doing root canals in single sitting because everything is thrown out. Okay, so one flare or one curve or two shape files always throw the debris out. So you can see 1, 2, and 3 canals which I have prepared. But there was one more canal which I could see over here. So this was the fourth canal which was there. So I pick up my 10 number K file and I start exploring the canal. I could get the fourth canal. So the roots were pretty narrow. If you saw it on the X-ray, the roots were pretty narrow, and the canals were narrow, and they were like the tooth looked more like 7. The canals usually are flared, but here the canals were very close. But in spite of that, there were 4 canals. And having 4 canals, having 2 distal canals in lower molar, in lower first molar, is pretty common. We see similar anatomy in more than 75% of the cases. So now preparing the fourth canal and irrigating and removing all the debris is must. Try and cut wet, always in wet canal. So this is what am I using over here is I use what I shown you over here was a 25 number 4% one curve. Before that, I will use my uh, 10 number K file, and now here I use my apex locator, try to reach to the apex. Now you can see it's almost a 21-22 millimeter molar, right? It's quite a long one, and measure it on the scale, and again go ahead and then go to the next canal, next canal, next canal. All canals we are going to take the working length. Once that is decided, do I reach the apex? No, I use apex locator, but I don't reach the apex. With this, again, you say, if you see it carefully, this is 22 millimeter, this is 20 millimeter line, and I'm reaching only up to 17 millimeters. I will prepare the canal gradually. I do not want to force the file inside the canal. I'm going one canal at one time. Usually, preferred cutting is wet cutting. Sometimes I may show you dry cutting because I want to show you what is happening inside the canal. Okay, now you can easily see all 4 canals over here, right? Now I pick up my K file handpiece, and you can see I'm using 21 mm K file, which is going full length inside. Okay, this is 10 number K file. I do not want to waste my time with my file preparing in the hand. I simply go in the canal and prepare the canal with my 10 number K file. Okay, so you pick up first canal, which is mesio-buccal. Then you go to mesio-lingual and prepare the mesio-lingual canal with 10 number K file. Few strokes, 3, 4, 5 strokes. Sometimes you may apply more. Now, what is the RPM of this? I use it on micromotor, so I simply keep it at around 3000 RPM. Trust me, file does not break at 3000 because it is reciprocation 30 degrees each side. It is not a circular motion. Okay, it's very safe and very interesting that it makes your preparation, K file preparation, very, very fast. So after this, if you can see the looking at the color, you can make out it is a 12 number K file. Okay, so I'm using 12 number K file to prepare the canal. Again, going full length, right? And prepare all. So from 10, I went to 12 because the canals were narrow, routes were narrow, canals were narrow. Now, because the canals were narrow and there were 4 canals, I have decided to keep my final preparation to 25, 4%. I probably will not go to 6%. I hate 7, 8, 9% taper preparations. That too much of eating away eating away too much of radicular dentin. I want to conserve dentin. For me, 4 and 6% preparations are more than enough. Irrigate, recapitulate, and again irrigate after every file. The canals are clean and clear, right? So again, now you can see that you can see it is a white file. You can see some portion of the file. It is white file, which is 15 number K file, and it practically takes me the same time, just few strokes, 3, 4, 5 strokes in each canal. At that speed is more than enough for us to cut. So I use 10 number, 12 number, 15 number. Now I am going to almost 20, 19 millimeter, 20 millimeter inside the canal and preparing it in all canals. So this is one curve. This is one curve, 25, 4% file, which I'm going in all 4 canals and preparing all 4 canals. It is a single file which I'm going to use. That's it. Now adjust it to full 21 millimeter. Okay. And after irrigation protocol followed, now I go to in all the canals to full 21 millimeter. So I have prepared only coronal third first, then even the K file which initially went to only 14, 15 millimeters inside, and I have been irrigating continuously after every file multiple times, 7, 8 times irrigation has already been done before I reach to the apex. So naturally the canals are going to be devoid of all the tissues. I'm not going to push anything beyond apex. So even if it is a non-vital case, I can think of finishing it in single second. Okay, here now I pick up GP points, put my 4% GP points inside, take this thing, diagnostic X-ray. If I require any corrections, I do them. The master code X-ray, if I require any correction, I do them. I follow my irrigation protocol religiously. What do I do? Now try to understand the irrigation protocol here. What I have just used is liquid EDTA. Liquid EDTA 17%. Okay, I am using liquid EDTA 17% in all canal and I'm activating it with ultrasonic device. I'm activating with ultrasonic device in all the canals. You can see an activation happening inside with this. Okay, once the so I have removed. Now I use sodium hypochlorite, and this sodium hypochlorite cycle is going to be 3 times. I'm heating the sodium hypochlorite in the canal with my AQV backfill gun. Okay, I'm showing you quickly, but the actual heating is around 4 to 5 seconds in each canal. Bring it close to the boiling point, and again ultrasonic device to activate it in each and every canal. So I'm activating it in each and every canal, about 15 to 20 seconds in each canal. Each canal, 15 to 30 seconds in each canal. Okay, 3 times. This you follow 3 times. Liquidity only once, but sodium hypochlorite 3 times. Now start drying the canal. This is a side vented needle. If you can see, I suck the solution from one canal and it got sucked from other. That means there is confluence. Both the canals are joining together in distal. And this is my master cone X-ray, which you can see over here. There is mandibular canal going from down, so I have to be extremely careful. I've seen enough number of cases as an endodontist where the sealer gets pushed beyond apex and enters into the mandibular canal. It is low 6 where mandibular canal is extreme. The roots are looking as if they are touching. They may not be, but I have to be careful. Use paper points, dry the canals, but they should not be super dry. Chamber should be dry, but the canal should be have little bit of moisture, not a visible moisture, but that is required for bioceramic sealers like Cerasil to set hard. Okay, so Cerasil comes in injection syringe form, with which I started injecting inside the canal. Okay, I start injecting inside the canal, inject the sealer. Now, first canal I have injected, which is mesiobuccal. I go to mesiolingual canal where I inject the sealer. Now I'm going to go to the distal canals. I inject in distobuccal canal and I can see the sealer coming out of distolingual canal. That means there is confluence, both canals are joining together. I do not need to fill the distolingual canal separately because it has been filled already. Okay, so once this is done, then we pick up our GP points and we start inserting. Here, the obturation is single cone obturation. Bioceramic sealers are fillers actually. They are such forgiving materials. Bioceramic sealers are really, really forgiving. Okay, so cut and take a ball burnisher or our EQV pack gun. So down pack gun with which I'm just severing the GP points at the orifice, only at the orifice, and then do some vertical condensation. Once you remove it at the orifice in both the canals, now you can see I did not enter inside the canal. At the orifice is okay. And this is such a fantastic bioceramic sealer, it does not affect its properties. So you now are going to do vertical condensation over here and create some nice colonal seal, okay, with some apical pressure. Okay, so these two canals filled. You do not require lateral condensation over here. We use these sealers itself are fillers. We use GP point just because, just in case if we have to do post and core and we have to remove the material from the canal, or if we have to do retreatment in future, we should have a soft core. And this GP point helps us to push, acts as a piston and push the sealer in the canal. That's why we use it. So third and the fourth canal over here, and GP is going to the full length, cut with the scissor, and again remove it. So all four canals sealed and filled, and you can see the obturation over here on the X-ray. Now it is extremely important for me to understand the proximity with the mandibular canal. So even if I, by mistake, and again you may find it this is short, no. I will go with my apex locator. My apex locator asked me to stop here, so I will stop here. My apex locator asked me to stop here, but this could be risky. If I would have put a little bit of sodium hypochlorite beyond apex, it could have created havoc. If I would have pushed the sealer beyond apex, I'm not saying that it will always go, because I may feel that the root apex is touching the mandibular canal, but it could be buccal or lingual to it. But I have seen enough number of patients having these kind of issues, so I will always restrict in this kind of. I do not want to see puffs over here in this kind of cases. If I have a puff and if it is going to fill up the canal, so it enters into the mandibular canal, I had it, because it becomes a really difficult case to manage. Then patient may suffer with paresthesia, which can be transient or permanent. So we do not want to have this kind of issue, right? So we lost the paper, the presentation. I will try to open it. I don't know why it will not. Give me a fraction of a second. I don't even see my presentation over here. I don't know. Anyways, we have covered all the things. Thank you so much. Maybe only one or two slides left because we had reached to obturation. We were discussing obturation only. So thank you so much and for this uh, opportunity with Dr. Reddy's DocMode and Euro Dental Academy. In Euro Dental Academy, we conduct international courses, and I'm the course director at University of Jamewan, and we conduct these courses, which are 6 months diploma courses, and we teach a lot of topics like this. If you felt that this last 1.5 hours was a learning for you, imagine spending time together for 6 months, and there can be so much of it to learn in endodontics. So I stop sharing my screen. Okay. Thank you. Thank you so much. Question times.
Thank you so much, Dr. Bajaj. It was, if I say it won't be an exaggeration, but it has been a treat listening to you and the entire lecture, the processes that you explained. Of course, they look very seamless and very easy, and I'm sure it will. Once it comes into practice, it will take some time for dentists like us to, master them. But I'm sure the information that you've imparted today is going to be very useful for our audiences. There are a good number of questions that we have. The most frequently asked questions, if I must say, are again, what are the indications for single sitting root canal treatment? And
Uh,
there is also a very interesting question as to when do we not go for a single sitting RCT?
Very good question. In fact, if you, I was expecting this question, and if I just said it, but I did not really put a slide on this. If you have noticed, because for me, most of the cases are single sitting. Most of the cases are single sitting, unless patient has got a massive swelling and I'm not getting the dry canal, then it goes for next sitting. If I get dry canal, it is single sitting case for me. Patient may have a huge periapical lesion. Patient may have the size of the periapical lesion does not decide whether we should do the case in single setting or multiple setting. Okay, that's the standards where we have reached internationally now. Most of the doctors internationally believe in single setting endo. So if you just follow your protocols properly, this is absolutely repeatable in each and every case. Okay, so we go with crown down technique. We do not push anything beyond apex. Why does the periapical lesion exist only in that tooth and not the neighboring tooth? Because neighboring tooth is healthy. What does that mean? It does not have decay. It does not have bacteria, and then leading to the toxins, and that is leading to granuloma or a cyst in the tooth. With this tooth has all of these things. You remove the source of the infection and everything heals. Body is a great healer. Okay. So for me, vital cases 100% single setting. If I don't get dry canal, it will go for multiple setting. It will go for second or third setting. There was a time when we all speakers used to promote a lot of calcium hydroxide dressings and other things. Gone are those days. We do not really require them. We rarely require them. Okay. So for me, if patient has got a massive swelling, he is in a toxic situation, he looks ill on the face, or if I open the RC and even after complete, for me, whether it is a single sitting procedure or a multiple sitting procedure, my cleaning shaping must get over in first sitting itself. And if I could do that, and at the end of it, I think I could get dry canals. I have know that I am not pushed anything beyond apex. I am going to use it. I am going to do the procedure in single setting. I will complete it in single setting.
Sure.
So that answers both the questions.
Sure. So maybe an add-on to this, what you've just explained, could pregnancy be also a deciding factor? Would you?
In fact, all the more reason that a pregnant lady does not get again for her treatment. She comes and she gets the treatment done in one go and she goes back home, right? So all the more happy lady, she may not even have to take antibiotics. So this works uh, as a win-win situation in every case. So coming back to Dr. Ketni, which you said, this looks simple, but it is not all that simple. Uh, yes, there are everything in life we have to master, and there are certain things which we need to master. When I say that, okay, use K400 and paste, use EQV, use some other crown down technique, everything that you do, we have to master, right? So likewise, we were not all used to these kind of webinars. We also had to learn, we had to master the techniques of doing them that frequently. So everything has got a learning of course. But I'm so happy that I meet so many dentists which we have had courses, we have conducted courses and they have attended or they have attended lectures like this. And now there are hundreds and thousands of them who use the same technique and getting incredible results in their practices day in, day out. So these are feasible, repeatable, and teachable techniques.
Absolutely. One more question that I have seen often, like maybe 2 or 3 times, is there a difference between the long-term prognosis of a multiple sitting or a single sitting RCT?
Well, there are studies which say that single sitting endo has got better prognosis, in fact. So, long term studies, in fact, are in favor of single sitting endodontics because you not uh, uh, leave the patient to the reinfection. I will put it in a simple clinical situation. 95% of the dentists are not using rubber dam. Okay, so every time patient comes in the clinic, sits in the chair, and we do little bit of procedure, and patient says, "Can I spit?" He goes, he spits, he comes back. The tooth is filled with saliva.
Absolutely.
Okay, again you irrigate with sodium hypochlorite and you expect the sodium hypochlorite to kill those 600 plus species of bacteria and whatever inside every time. So every time you in every appointment, patient is going to go and spit 4, 5 times or 6 times. Every time he fills his tooth with the saliva and comes back. When we are doing the procedure in single sitting under the rubber dam, patient does not really is going to go through all this, chances of infections, reinfections are much lesser. So the protocol, if you follow properly, the success rate is very, very high.
Sure. Um, so now there are some very specific case-based questions which I have. Probably I'll take one or two maximum. So this is a case from Dr. Rujita from Nasik. And she's asking if there is anterior fracture teeth due to trauma and the tooth is partially vital, but the patient showing positive POP. So is this case eligible for a single sitting RCT?
Well, this kind of specific cases, we actually ideally should be seeing the X-ray and talking about it. But if it is a
Right.
fracture case, meaning fracture at what level? It's a coronal fracture, root fracture, coronal fracture involving the pulp, not involving the pulp. If it is
Right.
involving, and in the fracture case, the pain on percussion is basically could be because of the trauma itself. That is
Right.
probably there could be a hairline alveolar fracture which we cannot see it on the X-ray. We may not notice, or there could be because of the trauma. There could be the inflammation in the PDL apparatus which exists over there. So it is not the infection or the pain because of the pulp tissue which has died. The pulp tissue is vital, as you mentioned over here. Okay, so if the pain is coming from the trauma. So that has again not to do anything with the root canal treatment. Again, case could be an excellent case for single sitting. But having said so, these kind of cases where the patient has had trauma, patient may have had a lip which is cut, swollen. There could be other areas. Patient could be in a state of shock, may not be able to sit in the chair for longer time. In that case, you probably will do pulp extubation, cleaning, shaping, and send the patient and call him for the second appointment. Please try to understand when I say single sitting endodontics, what I mean over here is minimum sitting endodontics. Okay, not just giving dressings and calling the patient again and again. No, I do not force the patient for single sitting every time. It is about minimum sitting endodontics. orthodontics will try and finish our case in minimum number of sitting, and that is the ideal scenario is single sitting. So we can take the next question.
Sure.
I'm sure you have to actually filter and rule out those
Yeah,
like common questions which are there.
yeah, maybe the last question what we can take. There is one question regarding implants. This is from Dr. Venkatesh Babu, and he's asking if the tooth is having periapical abscess and root canal is done, can we do an immediate implant placement?
Okay, this is actually any question related to implant is beyond the scope of this lecture. But I'll tell you, meaning for me, if I have to do immediate implant in a case where I have to, for some reason, but the tooth has to go for extraction because there is periapical lesion. Now, the lesion per se is not a reason for doing implant. In fact, there is less amount of bone in that area, and it's going to take long time to heal and have bone over here. The reason could be that root structure which is left over there is non-restorable, for which we are going to extract and put. Now, if you feel that the bone support to the implant is going to be excellent, implant is going to be stable, you can go ahead and do the implant in that case. Or a simple trick which I'll do. You have a root piece, okay, and that will require extraction, and you need to put an implant. What we can do is we can just do a little bit. We can do a mini shaping of that root piece. Put a calcium hydroxide type of dressing. Do not push it beyond apex. We do not want to have anything in periapical area over here. Give a close dressing and send this patient. Call him after 8 days. The root is sterile. The wound around is also gone sterile now because we have taken care of the source of the infection. Now you can go ahead and extract this root and go and place the implant. Now you almost know that even if there is periapical lesion, that lesion is sterile or it is the number of bacteria which are there in this lesion are minimum. Okay, so this is a small trick which I use in my practice, and I can do immediate implant in that case.
Sure. Maybe just one last question, which I really found, will help the audiences. If you can share any trick, particularly with respect to radiographs, because the radiographs form the most important basis on taking so many decisions during the endodontic procedure. So, how do you reduce the periapical radiolucency while taking the radiograph? Is there any trick or tips that you would want to share?
I probably did not get the question.
So,
How do you
the
reduce?
question is how to reduce the periapical radiolucency.
How to reduce periapical radiolucency on the radiograph? No, there is no meaning. I don't know what the doctor means. If I have to take out any meaning out of this patient, probably how do we see the healing happening on the radiograph? This is what he means. The pedia,
Uh, yeah,
as
maybe.
we take, as the case heals, how do we see? If we again, it's why does the periapical lesion exist? It is the bacteria which are harboring in the canal system. They are multiplying, but they do not have the canal system is non-vital. So whatever antibiotics we take just bypasses the canal system because there is no blood supply into the canal system now, into the pulse space. So the bacteria will exist. That's how typically patient asks us, I have infection. Can I simply take antibiotic and it will get cured? No. If somebody has done a poor root canal and patient now has got a periapical lesion, can just the course of antibiotic heal that? No. The treatment can be postponed with this, but you cannot heal the lesion completely because the bacteria which are harboring into the canal system cannot be killed with the antibiotic because antibiotic is going to go through the bloodstream and there is no blood supply inside. Okay, now we open the canal, we clean the canal system, we disinfect it with sodium hypochlorite or whatever, and then we fill it completely. We use either 3D obturation techniques to fill all the fins at the lateral canals or whatever we have in the system, or we use thermoplasticized gutta-percha systems, or we use bioceramic sealers and get a nice 3D obturation. We have reduced the bacterial load drastically. statistically. I cannot technically say that it is zero. There could be some bacteria which are there in the canal system, but we have practically buried them. In that case, we can expect that the periapical lesion will heal on its own. Try to understand, my friends. There used to be times when I did my post graduation. That time, in every afternoon in Nair Hospital, we used to do a periapical surgery, apicectomy. Either it is me or my colleagues in the department. There used to be one or two apicectomies every day. When I passed out, I must have done at least 150 apicectomies. But gone are those days. We understand the subject well now. And the number has now come down to maybe 2 or 3 or 4 apicectomies a year. And that too, not the true reason is not because there is periapical lesion. There's some anatomical things which we have not understood. There could be fracture, there could be one of the lateral canal which has not got filled. Most of the cases, you do not require periapical surgeries, apicectomies anymore. Just do the things. पैर में कांटा लगा है, there is a thorn in the toe, you remove it, and do you really have to do anything separate for that wound to heal? Do you have to fill up something over there? It is going to heal on its own. You remove the source of irritation over there. Likewise, we remove the source of irritation and things heal. A simple case which I showed, upper 8 distal canal missed. You saw that. It had a huge periapical lesion, right? If that lesion was there in the central incisor, I would have gone ahead and done apicectomy. But will I be able to do this apicectomy with the same efficiency in the distal buccal root of upper 8? No. So I'm just going to do root canal, and I know that tooth is going to heal. Right? We did apicectomy earlier in anterior tooth because it was convenient for us to do, and we do not do it in posterior teeth because it is not possible or easy for us to do over there, and we know that still those teeth heal. So if you want to see radiological healing, do the things right, and everything will heal.
Absolutely. Wonderful hosting you and having you with us, Dr. Bajaj. So I think we'll call it end of this webinar because there are so many questions, but due to the paucity of time, we would not be able to take all of them. But it has been a very exciting experience listening to you and just imbibing all of the endodontics that you've shared with us today. Before we wind up the program,
we can pick up few of the questions, and you can make a question answer booklet or something like that, and you can share it with either the digital copy or the physical copy through your representatives. We can share them in sometime in future.
Sure, I think that's a wonderful idea. We can definitely work on that. So before we wind up, just one important announcement. So the certificate for this program would be available on Monday, and you will be receiving a link, and you can download the certificate by clicking on that link. And once again, Dr. Bajaj, thank you so much for giving us your time and having being hosted you. It has been a wonderful experience for us, and we will definitely look forward to having more of sessions with you on endodontics and other topics. Of course, this was a very less time for to discuss in depth about so many things, because this is probably just a touch and go kind of a session, but still I think it has benefited the audiences really. And probably sometime in future we can have a little longer session where we can discuss in depth about certain aspects, finer aspects
of exactly. We can pick up one of the topic and we can discuss it in detail in sometime in future.
Absolutely.
For sure. Thank you so much. Thank you so much, Dr. Kirti. Thank you, Dr. Reddy's, for giving me this platform. Thank you, DocMode. Thank you, Eurodental Academy. And we just discussed this and we came to this, and I think this is webinar number 1 in the series of 3, right?
Right.
And we have got 2 more to come up.
Yes.
Thank you so much. Thank you.
We will be having the next webinar in the next month, September, for which the date will be announced soon. And until then, have a pleasant rest of the evening and wish you all a very happy 75th Independence Day in advance. So, good evening and have a good day. Thank you so much.
Wish you happy Independence Day in advance on the eve. And thank you so much. Take care. Keep following social distancing. Keep following all the protocols in your clinic. Nothing has changed. In fact, virus has gone more virulent. Please keep following everything. Take your vaccine dose. Encourage everyone to take it and try and be safe. Thank you so much. Bye bye.
Thank you. Bye bye.